For those who have joined, we're going to just wait about 30 more seconds to make sure that we allow everybody to join who would like to be a part of this session. So it looks like the people who are logging in, the rate seems to be slowing down, so I'm going to get started in the interest of time. Hi, my name is Matt Lillyblad. I'm a clinical pharmacy specialist at Abbott Northwestern Hospital in Minneapolis, Minnesota, where I work closely with our advanced heart failure section of the Minneapolis Heart Institute, as well as our intensivists in the management of patients with ECMO. And anticoagulation is a particular passion of mine. So I appreciate the opportunity to speak to you all about some updates related to anticoagulation in those patients who are supported with ECMO. In the interest of time, I'm really going to focus on the agent selection aspect of it because it's been the most dynamic in the literature. In my experience is with adults, so this is very specific to the adult population as opposed to pediatrics. My disclosures, I have no other financial relationships with pharmaceutical companies or ECMO companies or anything along those lines. My paycheck solely comes from Allina Health, which is our 13 hospital health system in Minnesota and Western Wisconsin. I'm not going to spend too much time on background because I think most of you all who are listening have lived through the clinical conundrum that is anticoagulating patients on ECMO. Unfortunately, despite all the advances that have been made in the technology and our understanding of how ECMO affects physiology, we're still not at a point where patients are able to tolerate support without some level of anticoagulation in most circumstances. So since we need to prevent thrombosis within the circuit or thrombosis within the patient, anticoagulation is required at this point. And unfortunately, with the addition of any level of anticoagulation to a patient, particularly ECMO patients who are already at high risk of bleeding, you do increase that bleeding risk. And so the question becomes, how do we safely and effectively do this? When we're making those decisions, there's really three critical questions that come into play. What agent should we use? What should we do to monitor these patients for the intensity and what that intensity should be? As much as I would love to talk about all aspects of this, with having only 20 minutes, 25 minutes to highlight this topic, my focus, as mentioned previously, is going to be specific to agent selection because of how dynamic this has been over the last 3 to 5 years. When we talk about anticoagulation in ECMO, and really anticoagulation in any patients, there's some critical aspects or characteristics of the anticoagulant that we want to have to create this ideal agent. Unfortunately, that ideal agent doesn't exist. But since the ideal agent doesn't exist, the opportunity to have options allows us to tailor care to the patients and optimize that care. And so first characteristics pertain to the kinetics and pharmacodynamics of the agents themselves. So we want something predictable. We want a stable level of anticoagulation throughout the support and quick onset and offset. From a usability standpoint, we want reliable monitoring. We want the ability to reverse the anticoagulation if we get into a situation where we need this. We would like the adverse effects to be minimal with these medications, particularly not only with the bleeding risk, but also with kind of the off-target non-bleeding adverse risk potential, and then minimal drug interactions. And then finally, and probably most importantly, our ideal anticoagulant is going to prevent thrombosis or thromboembolism with a minimal level of bleeding risk to hopefully optimize the survival, minimize the complications, whether it be for anticoagulation in general, or in this case, during the support with extracorporeal membrane oxygenation. So the good thing now, what we've learned, particularly in the last 5 years, but probably the last 10 to 15 years, is we do have anticoagulation options that can meet some of these needs and have some of the characteristics that are ideal for patients supported with ECMO. So high level, the two classes are the heparins and the direct thrombin inhibitors. When we talk about heparins, really we're focused on unfractionated heparin. The low molecular weight heparins are going to be particularly challenging to manage in a patient on support with their long duration of effect, as well as the impact renal function has on the ability to dose. So when I speak of heparins, my focus is on unfractionated heparin, and we all realize that heparins have been really the mainstay for anticoagulation when it comes to ECMO since its inception as a direct descendant of cardiopulmonary bypass. New to the game, particularly in the last 5 years, is the use of direct thrombin inhibitors. Right now, the commercially available direct thrombin inhibitors, at least in the US, are bivalirudin and argatroban. Both warrant a discussion. In the interest of time, my focus really is going to be on bivalirudin because that is where the majority of the data exists. But I'll try to give a little bit nuggets about argatroban and the considerations around argatroban as we go through this. So this is really the precipice, the rationale for focusing on agent selection as opposed, or agent selection when it pertains to kind of updates related to anticoagulation. There's been a smoldering interest for the use of direct thrombin inhibitors in ECMO for a while, with really the early studies being kind of in the 2009 to 2011 range. But this is kind of a graph that shows a publication rate of actual studies. So I didn't include case reports, and I focused on studies that were interested in investigating the use of direct thrombin inhibitors as opposed to heparin as a first line. So I omitted studies that looked at the use of direct thrombin inhibitors specifically in HIT, because that's not necessarily selecting it from a first line standpoint. That's adjusting therapy as we go through. Moral of the story is you see that since 2018, there's really been a steady stream of publications related to comparing heparin to direct thrombin inhibition, particularly bivalirudin. Now, the overall numbers are not enormous, but if you think about how niche the situation is, and the fact that there really isn't any industry backing or industry promotion of these products, in that it's pretty miraculous that we've had this many studies in this short period of time of basically just centers sharing their experience. And all the authors of these studies should be applauded for sharing their experience, because in the absence of a randomized controlled trial, which we do not have at this point, these studies are really incredibly important to help guide us in our agent selection and our ability to utilize direct thrombin inhibitors safely and effectively in this population. So the kind of the organization of this presentation is going to be centered around those optimal characteristics of the optimal anticoagulant, and I'm going to touch on a few specific aspects in each section. So as it pertains to the dynamics and kinetics of the drugs, I want to focus on predictable dose response and stable dosing for this particular situation. So despite heparin being a mainstay of anticoagulation for ECMO, it comes with a lot of warts. It's not ideal in its predictability, not only related to its efficacy, but also its metabolism. So its reliance, it's not a direct inhibitor of thrombin or anti-10A, so it relies on antithrombin to help assist in the anticoagulation, facilitate its anticoagulation effect, and that can be a dynamic factor in patients. It's also its metabolism can be skewed based off of the degree of macrophage binding, endothelial cell binding, plasma protein binding, and so maintaining a stable level of anticoagulation can be a challenge. It is not perfect by any means. And really the reason for the interest in bivalirudin and to some degree argatroban is that it has the potential to overcome those limitations of heparin. So it does not rely on antithrombin 3 for its efficacy. It's a direct thrombin inhibitor, and it has more reliable pharmacokinetics as it pertains to its metabolism and renal elimination. And so the idea here being, if you can provide more stable level of anticoagulation, maybe that would lead to better outcomes. I wanted to focus in on some of the outcomes related to dosing stability that have been published in the clinical trials that we have, or the retrospective trials that we have. There is no definition of dosing stability. There is no established outcome that all studies have measured. All these studies have somewhat looked at dosing stability in different ways, whether it be degree of percent difference in APTT from check to check, whether it be the number of dose adjustments in a day. But one outcome that's quasi-consistent is the percent time in target range and or TTR. Now TTR, we know of that in terms of from a warfarin standpoint, the outcomes have not been as well established in this, but it's still kind of, it methodologically makes sense to look at it in that fashion to see how stable our dosing is when we're comparing the direct arm inhibitors to heparin. You can see in the bivalrudin arms of these studies, in most of them, a pretty consistent high level of stability in terms of target level APTT, which is a great thing to see, and in many cases statistically significant over heparin. One thing I do want to point out is that having such these TTRs and percent time and target range for heparin are very low. With heparin, with all the warts of heparin, you still, if you have a time and target range that's sub 50%, it may be worth looking at the protocol itself to see if the protocol is attaining the level of anticoagulation desired and that the dose adjustments are working. In my experience and the amount of work that we've done with heparin and the quality of our heparin protocols, you should be able to have a protocol that probably gets in the 50, 60, maybe even 70% range. And so if you're lower than that, it may not be necessarily all the heparin to blame, but that the protocol itself also needs to be looked at. But nonetheless, bivalrudin, I don't think that most people would be able to get to the level of bivalrudin stability that it's in these studies. It's pretty remarkable. Next, I want to talk about the usability, and from the usability standpoint, we're going to look at the reliable monitoring, its reversibility, and then the kind of off-target adverse drug reactions that we can potentially see or not see depending on the agent chosen. These are the ELSO guidelines around monitoring. It's been a hot debate for years about what is the ideal monitoring parameter for anticoagulation intensity, with really a focus on heparin. Is it ACT, APTT, or anti-factor 10A monitoring? The ELSO guidelines support the use of all of them, which really reflects the fact that we do not have a test that is perfect, and that each of these tests actually tell us something different. So there may be value in checking all of them and understanding where the discrepancies lie, and how the patient is behaving to kind of tailor the level of anticoagulation that we're providing to that patient. The really nice thing about heparin is that we have this anti-factor 10A assay, which is very, very specific to heparin itself. Unfortunately, with bivalrudin, we don't have something that's as mainstream. There's diluted thrombin times, there's eccrine clotting times, which are not available necessarily institution to institution, especially eccrine clotting times, it's a very specific measurement. It's a very specialized measurement that actually very few labs can actually do. And so we have to understand that if we are going to use bivalrudin as a first-line agent based off of the outcomes that we'll talk towards the end, that we're not going to necessarily have that assay. That helps us know exactly what the bivalrudin is doing and not influenced by other patient-specific factors. And the kicker is that there is a lot of things out there that can impact ACT and APTT, which can be used with bivalrudin. But there's a lot of factors that these patients can experience that can make them I'm not saying false, but not necessarily reflective of the level of anticoagulation that the bivalrudin itself is providing, and the same can be said with the argatroban. So just understanding that limitation is going to be important in the safe and effective management of these patients. When we talk about reversibility, there's really two ways to reverse anticoagulation in these patients. We have actual reversal itself, so using an agent to neutralize. The nice thing about unfractionated heparin is we have protamine. From a bivalrudin standpoint, we do not have a specific reversal agent. There's some suggestion of using recombinant factor 7A out there. Personally, factor 7 replacement terrifies me. It is very thrombogenic, and we would be using a population that is prone to thromboembolism. So extreme caution there when utilizing that agent for reversal. But if we don't have reversible agent, can we use the half-life? Is the elimination of the drug itself fast enough where reversal agent is somewhat unnecessary? With heparin, 1.5 hours, when a patient's having a major complication, that can feel like a lifetime to wait a couple half-lives for the elimination. But with bivalirudin, what's often quoted is this 25-minute half-life, which is very quick. I mean, if you can think about 75% of the drug being gone in about an hour, that is good. That is quick reversibility, in a nice characteristic to have in a drug. The one thing I want to always caution with, though, is that is under normal, perfect renal conditions. And so when you have progressive renal dysfunction, that half-life prolongs. And that's often not discussed when people are talking about the use of bivalirudin and ECMO, particularly in a population that may be prone to renal dysfunction, especially our VA populations who are, spend some time in cardiogenic shock preceding cannulation. And so just understand that that pretty 25-minute half-life is not necessarily going to be the case when a patient starts approaching the need for renal replacement therapy or is on renal replacement therapy. And then the last part of the usability section is these, off-target adverse drug events. When it comes to bivalirudin or gachaban, there really isn't much, right? The bleeding risk is the primary issue, and it really doesn't cause much in the way of issues otherwise. With heparin, we have the dreaded HIT, and which is a very important complication, something that we have to monitor closely for, and can be detrimental even in the most straightforward patient. But when you talk about a patient on ECMO and having HIT, it can quickly become a catastrophe. So understandable that there's concern there. I just want to point out with this study, this is the largest, most comprehensive, albeit retrospective study that included a bunch of ICUs in France, looking at a ton of patients, looking at the actual incidence of HIT in the ECMO population, and the actual percentage of SRA positive HIT was quite low, thankfully. Now, it wasn't zero, so it's still a very important potential adverse drug effect, but just note that we're not seeing this as high as some other populations or greater than some other populations. And when those HIT positive patients were managed appropriately with direct thrombin inhibition, what they didn't find was differences in membrane oxygenator changes, arterial thrombosis, venous thrombosis, or mortality. So finally, and probably most importantly, is the clinical outcomes aspect. This is really what we care about, aside from all the ease of use and the adverse drug effects. Ultimately, what are we, can we achieve better outcomes with our ECMO patients depending on the anticoagulant that is used? And so I'm gonna look at it from a thromboembolism, a bleeding risk standpoint, and then overall survival, and center in on some of the studies that exist, particularly the ones in the last 5 years. And so this is the same graph as before, but you can notice that in the last couple of years, we're starting to see some studies where bivalirudin is found to be superior. I think the great thing is aside from the superior studies, that all other studies have been neutral. So there has never been a study of patients where bivalirudin or our gachaban has had worst clinical outcomes when compared to heparin. So let's talk a little bit about the outcomes we're looking at more specifically. So on the left-hand side here, we see the three studies that show a reduction in bleeding risk. Again, some of the three most recent studies there. I would like to point out here that the Tong study from 2003, that 0% bivalirudin major hemorrhage rate is, I'm not gonna lie, a little hard to believe. I think we would all love to strive for 0% major hemorrhage rate. And it's a little bit hard to interpret because their definition of major bleeding was not clear. So they did not use, or at least they did not describe, they used a standard definition like ELSO bleeding or BARC bleeding or ISHT bleeding or anything along those lines. It was just what they described as major bleeding, and that being 0%. But we do have some studies here. Whenever we talk about these recent studies that are positive, we want to look back in the context of all the studies that exist. And so there are a lot of neutral studies out there when it comes to major bleeding, more neutral studies than there are studies that showed a benefit from this standpoint. When we talk about thrombosis rates, again, we have a couple studies here that saw reduction in thrombosis rates. Now, when we talk thrombosis, is it circuit thrombosis, is it patient thrombosis, is it both? And so the Rivasecchi trial looked at circuit thrombosis specifically and saw a reduction with the bivalirudin. The Rikios trial looked at all overall thromboses and then normalized it per day of support, which is actually probably a better way of looking at things, and a statistically significant reduction. Again, though, we have a handful of studies, or more than a handful of studies, almost 2 handfuls of studies that showed that the thromboembolism, whether it be patient or circuit, is similar between these bivalirudin and heparin. And then finally, ultimately, is overall survival. And we'd hope that any change in outcomes that we see, whether it be thrombosis or bleeding, ultimately leads to survival benefit. And that was the case with the Rico study. They had both a reduction in thrombosis and a reduction in major bleeding, and that translated into a reduction in all-cause mortality at discharge. The Seelhammer is a little bit more challenging for me to interpret because, number one, they did not look at any bleeding outcomes in that study. So we don't know what the bleeding rates were between the two. And then the thrombotic outcomes were equivalent, but they did find a reduction in all-cause mortality. So the question becomes, how? Was it chance? Was it bleeding and they just didn't measure it, but that was what led to it? We don't know any pleiotropic effects of bivalirudin where that non-bleeding, non-thrombosis, there would be a benefit there, like anti-inflammatory properties or something like that. So not entirely sure how to interpret the outcomes of that trial, but the vast majority of trials out there do show neutrality when it comes to all-cause mortality at different time points, depending on the study that's looked at. So when we have this heterogeneity in outcomes, I think it's important to not necessarily just focus on the most recent studies, but to look at them in the context of the whole. And is there differences with the more recent studies or the positive studies as opposed to the neutral to explain why these patients did better? Or is it just by chance, or it's specific to their population, because all of these studies are single center. When you look at study size, heparin intensity, bivalirudin intensity, ECMO configuration, VA versus VV, the stability, the way they define the outcomes, there wasn't a clear trend on why the positive studies were positive. What about the positive studies made them positive as opposed to the other ones? They were all very similar. One thing that was a little bit different is in the more recent studies, based off of, I think, what a lot of us have learned with bivalirudin, is that their initial dosing of anticoagulation, particularly with bivalirudin, was more conservative than what you would normally use in HIT. And so maybe that helped with those early bleeding outcomes and not blasting a patient with too much bival right off the bat. Who knows? But that was a trend in the more positive studies. So really, we don't know at this point what made the positive studies positive, other than that, the specific center experience. One thing I do want to point out that is evident, that in the positive studies, all 3 of the positive studies, whether it be with bleeding or the 2 with thrombosis, what they described in their methods is that earlier on in their years of the study included. So you look at the range of study of the study in terms of the years of that they used. The earlier years were with heparin and the later years are with bivalirudin. I think any ECMO center, anybody who's a part of ECMO center, wants to see that over time they get better at managing their patients with the experiences that they gain with the way that technology has evolved, especially in these wide year ranges that are included in these studies. And so it does beg a little bit of the question on how much of that improvement in outcomes was actually bivalirudin versus them getting better at supporting patients on ECMO. I'm not sure if that's the case, and bivalirudin could still be a part of the value added and what they've learned over the years to help with those outcomes. But I think that's a really an important thing to note and something to consider as we continue to study this in the future. Check my time here. So in the interest of time, I'm gonna go a little bit quicker through here, and I hope you guys get access to the slides for your reference. My conclusion on this is that direct thrombotic inhibitors are absolutely a reasonable alternative to heparin, whether you choose it as the first line or use it as an after heparin if a patient kind of quote unquote fails heparin. I think we should be confident in our use of direct thrombotic inhibitors. Whether one is superior to the other, I'm not ready to say that one is necessarily superior to the other. I think each has its benefits, each has its risks. And so we have an opportunity really to tailor how we do or our anticoagulant selection to the patients that we see at the patient level. I won't go belabor this, but we do thankfully now have multiple guidelines related to ECMO and anticoagulation. There is nothing other than the ISTH, which gives support to unfractionated heparin as the primary anticoagulant of choice, but acknowledge the potential role of bivalirudin. Really, the guidelines don't push us one way or the other. We don't necessarily have much in the way of randomized controlled trials on the way. Hopefully that becomes a thing soon. This was clinicaltrials.gov that I looked at on Monday. But we don't see something on the horizon necessarily being published. So we got to use the data that we have. So I think this is like the most important piece of it before I wrap up here in the next 3 minutes is I think you can justify using bivalirudin first line. I think you can justify using heparin first line. I think the most important thing is being agile from a program standpoint to be able to pick one or the other depending on patient circumstances, whether that's on the front end and bivalirudin is a workhorse, but you're going to use heparin in some patients or vice versa. I think that is how we really improve outcomes, to be able to tailor anticoagulation selection either on the front end or in response to the way the patient's behaving during support. So if you are a heparin hospital using that first line, when I would consider bivalirudin, obviously with HIT, if a patient's having heparin resistance, I would use bivalirudin over supplementing AT3. If you have non-HIT thrombocytopenia that we see a lot, you might get some platelets back by coming off heparin, or if the heparin has been failing the patient and the patient can't tolerate heparin, or the patient keeps clotting through heparin, it's worth trying something else, in my opinion. If you're a bivalirudin first institution, I think you should consider unfractionated heparin, particularly if there's insufficient cardiac unloading in VA ECMO. We can spend 15 minutes talking about this, but bivalirudin is not very protective of stagnant blood. And if there's stagnant blood within the cardiac chambers, it is not going to necessarily provide direct anticoagulant or sufficient anticoagulant effect for that blood stasis. That's been described in the literature. I've seen it firsthand a couple of times. Argatroban can be an alternative in that setting because it doesn't have the proteolysis metabolism. So consider that. We just did that a couple of weeks ago in a patient successfully. If the APTT is unreliable because we don't have that equivalent to anti-10A monitoring, we could use, we should probably maybe use something that we can monitor a little bit more closely. Severe renal dysfunction, maybe, but you can adjust for dose here. And then the bivalirudin failures is a time when I would switch back over to unfractionated heparin. This is just some pearls quick on dosing if you are looking at switching to bivalirudin or assessing your protocol and the way to adjust. The key here is to protocolize this. Do not just run it as a fixed rate. I know that's what was done with PCI. But under these circumstances and with this level of bleeding risk, there should be consistent monitoring and adjustment from there. So this is the conclusion side here. I think in the interest of time, I'll stop to allow you guys to move on to the next section. But I again very much appreciate you guys attending this very quick session on anticoagulation, ECMO, and feel free to reach out if you have any questions or thoughts on this.